Hey, good morning, everyone. Let me know if you can hear me. All right, thank you, Madeline. We'll start here in just a few minutes. 6. Good morning, Candy. This will be the last lecture before the test, I believe. Huh? Excuse me. Hopefully, you guys. I know you didn't hear that. I was able to mute it, but. Valerie? The buffalo humps go away after patient discontinues protease inhibitors. I would imagine it does, but it takes some time. I've not read anything specifically regarding that, but I would imagine once the drug's effects are gone, then you'd start to see sort of a redistribution of that fat. It might take a while, I would imagine, but certainly something that would be nothing permanent about it, I would say, as long as the medication's not around. So. Any of you in? Most people were still enjoying their spring breaks. I said, no, skip out on. I don't blame you. I wouldn't want to do farm at 8 o'clock in the morning either if I were y'all. All right, well, I got a lot to cover, so let's go ahead and get started. So whatever I finish today is going to be what we'll be covering on our exam material. So if you recall, I believe I have everything up through everything past the epilepsy section. So Parkinson's and all of that from the neuro up through the migraines and all of that. We'll have behavioral health, we'll have the HIV/STD stuff, and whatever I finish today from the peds Jerry section. So shouldn't be too bad. We'll see what I get to today, depending on how much I'm talking. But yeah, so no questions. If you do have questions about exam stuff, feel free to post them up. I don't mind being sidetracked. I might wait till the end to ask or to answer them, just to make it all kind of concise and put it all together. Yeah, any questions at all that you guys have, feel free to post up and we can do a little bit of a review for some of that stuff. Anyway, so we talked about main treatment for HIV. We talked about acceptable combinations of drugs, things like always making sure you have 2 NRTIs plus like an integrase inhibitor or a protease inhibitor. We talked about drug interactions with things like our CYP3A4 inhibitors act as boosters. So we covered a decent amount in terms of treatment, but let's talk about what happens for patients who maybe are not being well treated, or maybe they're non-compliant. Something's happened to where now they're developing some complications of HIV, and they've developed now AIDS as a result of this. I won't cover every single opportunistic infection out there. I'm mainly going to focus on some of the more common things you'll be seeing, especially as a patient's CD4 count starts to decline and you're starting to see them being more at risk for some of these, infections and things like that, that, normal healthy individuals will not be susceptible to because they have a functioning immune system, but these patients may not. And so prior to having antiretroviral therapy, this was the main focus of trying to prevent and treat these opportunistic infections, because this is oftentimes what was killing your patients, basically. And again, these are things that are common in the environment that we can fight off no problem. But if you have, a CD4 count of less than 200, that becomes much more difficult. And even some cases like TB, for instance, you can have reactivation of latent infections that have been sticking around for a while, and now all of a sudden they become active. So our main focus is to try to keep their CD4 count up, keep the viral RNA undetectable, and that should help to prevent a lot of these. So if you can keep their CD4 count in a pretty good range, you should be okay there. But typically what we'll do is we can try to prevent exposure. That's always helpful, which may be difficult depending on the situation. And if we can vaccinate, in some cases that can be helpful as well. You'll see for a lot of opportunistic infections, that's not really going to be possible. But the big thing that we do here is chemoprophylaxis. It means that at certain thresholds for the CD4 count, if it drops below a certain level, we'll then initiate prophylactic therapy. So we'll talk about some examples of that. If an actual opportunistic infection occurs, and we go ahead and treat that as need be, and then they oftentimes will go back into what they call secondary prophylaxis, trying to prevent any recurrence from disease happening there. And then if you do have a sustained recovery in their CD4 count, it goes back up because now they're on antiretroviral therapy. Then you can discontinue that prophylaxis once you're kind of above that certain count limit. And again, this is not all inclusive, so you can check out the aidsinfo.nih.gov. This is the #1 resource to go to for up-to-date info, because this will change from year to year because it's a very rapidly evolving sort of disease state, and you can see what the guidelines currently are. So I'm just going to cover a few of the more common things you're going to run into. But sometimes what you will see is that patients may have longstanding HIV for years potentially and not get diagnosed until they actually come in for one of these opportunistic infections. So if you see someone who is otherwise doesn't have any kind of past medical history, but they have a candidal infection, like they have thrush, like that doesn't seem to be something that's normal in a patient with a normal immune system, and you can't find any other obvious cause, and that could be it. That could be your first time you're diagnosing HIV there. You might run the test. And so you're going to see that there can be some benefits for helping out with that immune recovery when starting ART. So it's nothing to say you can't start both therapies for OIs and for the ART at the same time. But you're going to see there's lots of drug interactions that can come about from this, especially for things like tuberculosis and whatnot. And also this could be really tough from compliance with a large number of new medications. Again, given their social situation, things like that, they may not be able to afford a lot of this stuff. They may have limited access to stable home and things like this that may make it difficult to be compliant. So again, this is why we have to have a lot of things like social work and all of that to kind of help us out with from that standpoint. And an interesting thing that can also happen too is called IRIS, or this immune reconstitution syndrome that can occur here, that's associated while treating someone for an opportunistic infection, and then you start them on antiretroviral therapy. What actually ends up happening is it seems like the patient's getting sicker, and that's mainly because you're allowing their immune system to sort of kind of come back online to some degree, and that causes a lot of inflammation. So it's one of those things where it's like, yes, the patient seems like they're getting worse when actually they're overall getting better. The patient may not feel the same way though, so that can be kind of tough and something you can kind of educate them through. So some of the more common ones you're going to see, and again, I focus on the ones we typically you'll see a lot of prophylaxis for because these are more common or they happen at higher CD4 counts. So pneumocystic Jiravecki pneumonia or PJP pneumonia. You may see this as PCP pneumonia. Again, the nomenclature changes as time goes on. This tends to be the most common life-threatening opportunistic infection here. And again, I see this most commonly for patients who we have made immunocompromised. This is usually for cancer treatment. So you'll see similar sort of chemoprophylaxis in both cases, patients with maybe more immunocompromisation due to HIV and for things like chemotherapy. But this is a fungus that has sort of protozoal characteristics, and so it's kind of an odd little bird there in terms of an infection. And you're going to see a lot of people get exposed to this all the time, but they don't develop infection because they have a competent immune system. And you can see here how it will develop this really severe pneumonia over the course of some weeks. And so the treatment of choice for this is actually going to be Bactrim, so sulfamethoxazole trimethoprim. And you notice here the treatment time is a lot longer because these are a difficult to treat infection, and then two, the patient may not have a competent immune system to really fight this off. And so a lot of times when patients come in, and again, these are like really, really severe pneumonias, you'll see them start off on IV Bactrim, which is not a very common thing we do. And then as they start to recover, we may switch them over to oral. The more frequent thing you're going to see here is we'll actually start them off on prophylaxis. So as their CD4 count goes below 200, or if they have like a history of thrush, we'll go ahead and start them on Bactrim. And you may see that as like, they may be on like Bactrim twice daily on Sunday, Saturday, Sunday, or they might be on thrice weekly, like Monday, Wednesday, Friday. So if you ever see something like that, that's typically what that Bactrim is being used for, is for chemoprophylaxis. Again, we will then see if they have the infection, they get treated for that, and then you'll put them on secondary prophylaxis as well. So you may see it either as primary prophylaxis where they never had the infection, or maybe secondary where they had the infection, they were treated for it, and now you start them up on the secondary prophylaxis there. Just depends. Candidiasis or thrush is another common thing you're going to run into with these patients here. The problem with this is, you can have someone with a competent immune system, say they're using something like an inhaled corticosteroid, like, fluticasone or something, and they can develop a thrush infection there. And again, that's something that we're not too concerned about because they're unlikely to have an invasive sort of infection, whereas with these patients here, even having that oropharyngeal candidiasis can then spread and can lead to, fungemia and things like that. That can be really devastating to the patients. Yeah, David's asking, why does an antibiotic work against the fungus in this case here? It has to do, I think, with sort of those protozoal characteristics that Bactrim does have some activity against. And again, think about how the sulfamethoxazole trimethoprim is working. They work on blocking the utilization of folic acid by the organism to prevent things like nucleotides to produce DNA and RNA. So even though it may not be as specific for certain bacteria, this does have some crossover effects and can still affect them. It's not like, a cell wall active agent where it's very specific for bacterial cell walls versus fungal cell walls. So here you can see that the target could be kind of similar. So that's why we do see some activity there. So again, the best thing for these patients here is to try to prevent the candidal infections in the first place. And then, so you may see them use something like nystatin, where they'll typically have like the oral liquid form. And remember, nystatin's a good antifungal that doesn't get absorbed. So it's good for sort of that oropharyngeal treatment. You can have them swish and swallow or swish and spit about 4 times daily. And this is going to be good for the oropharyngeal candidiasis and can kind of help treat that. May not get as good a coverage for the esophageal candidiasis. In those cases there, you have to use something like fluconazole. And so again, the goal is to prevent them from developing a more systemic infection, because once that happens, it can be, again, quite difficult to treat. You have to start utilizing some of your more kind of hardcore antifungal drugs like amphotericin B and, voriconazole and things like that. So these are the main things we'll use to try to either treat or prevent sort of the more minor thrush infections you'll see there. So there's no specific recommendation for primary prophylaxis, so you'll see that being used once they develop the infection, which again you can see on usually on the oral exam. You can just kind of look in the back of the throat and see those white plaques that are forming there. Other things you'll run into include things like cryptococcal meningitis, toxoplasmosis, MAC or Mycobacterium avium complex. Again, some of these, I'm not going to get into the specific details on a lot of these. These tend to happen as the patient's CD4 count becomes even lower and lower. So for instance, like MAC becomes a problem, I think, once you get less than like 50 on your CD4 count. And sometimes you'll run into patients who have like a single digit CD4 count and they're just really at risk for all of these types of infections here. So again, if we can try to prevent them by either having less exposure, if you can vaccinate, things like that can be helpful in some cases. Is nystatin safe for infants to swallow 4 times a day, or would be less frequent? No, we'd still use it pretty frequently, and those patients there, it really just does not get absorbed at all, so there really wouldn't be a problem. Sometimes what we'll do for infants like that is we may just do like a swab, because it's kind of hard for them to do kind of the swishing sort of thing. As with an infant, you couldn't really get them to cooperate. So if you can get like some kind of like Q-tip or something like that, and you can kind of swab it with a drug on there, that can be done in order to treat those patients there. So So as I mentioned last time we talked, these patients are living for longer, which is great. This used to be kind of a death sentence back in the 80s and early 90s, but nowadays they're starting to develop sort of like secondary problems, so diabetes and hypertension and all these things related to the medications that we're giving them in some cases, or just them getting older and developing these chronic conditions. You want to watch renal function as well, because they can develop what they call an HIV-induced nephropathy, so that's something to watch out for there. And of course, it could be at risk for certain types of cancers, so things like lymphoma and hepatocarcinoma and things like that. Again, just always look for drug interaction. So if I'm starting someone on, say they're on a protease inhibitor and they're on cabigastat as a 3 or 4 inhibitor to boost up your protease inhibitor, make sure that, if you start them off on a statin, you're not going to hit them on something like simvastatin, right? Because, those levels will be too high in those cases there. You'd want to use something like atorvastatin or rosuvastatin in those cases. Yeah, so Christine's asking, is nystatin more for minor thrush and fluconazole is esophageal, more severe thrush? Yeah, so if it was something to where it was just kind of just really relegated to the oral pharyngeal cavity, then yeah, I think that's probably something where nystatin would be pretty good for that. If it's starting to kind of spread down and become more esophageal, then yeah, you want to use something like fluconazole for those more kind of involved infections. That's going to be better too for if it does become systemic. So yeah, so that's what I would say for that. Okay, so let's talk about sexually transmitted infections. Now, this joke makes more sense if we were actually in person, because actually I drive an STI, so sometimes that's kind of, you'd see this in the parking lot perhaps, but just suffice it to say, I drive a car very similar to this, which is called an STI, and my wife is not thrilled when I bought the car, because she's like, great, now you have an STI. You cheating on me? It's just kind of funny, but anyway, so let's talk about sexually transmitted infections here. So, again, I like to talk about these along with HIV because, again, in terms of like sexually transmitted diseases, they kind of go hand in hand to some degree here. And so we'll kind of hit on the most common ones you're going to see. Again, some of these guidelines will change over time. So just be aware, you may need to go look this up. CDC is the best resource for this stuff. So I would definitely recommend checking out their guidelines if you need something that is kind of the most up to date. So first off, you have Neisseria gonorrhea. It's a gram-negative diplococcus here, and issue with a lot of these STIs, especially gonorrhea, chlamydia, is the fact that a lot of people are asymptomatic, and so it's very easy to kind of spread this around without really people even knowing they had the infection in the first place. The reason why this is a problem, especially for female patients, is again, this can delay treatment because it has sort of non-specific presentation and can lead to issues like pelvic inflammatory disease, can lead to systemic infections. And not only that, but it's really sort of interesting that HIV spreads more easily in patients with gonorrhea. So you can see sort of a synergism here, amongst these different diseases and how they can kind of help spread one another to susceptible individuals. So not great. So this is why we like to get this treated. Main treatment of choice here is going to be just a single IM dose of ceftriaxone. And again, you don't even need really that big of a dose. They're about 250 milligrams. They've found that if you give like courses of oral cephalosporins, they tend to not work quite as well as the IM, because again, it does have good bioavailability when injecting it. The other thing too is that with a lot of these, you want to ensure compliance, and so if you can give them a one and done sort of therapy, like in the clinic, in the ER, where they happen to be, when they get diagnosed, that's going to be ideal, because you don't want them to be on a 7 or 10 day course or something, and then maybe they don't fill the prescription, or maybe they don't stick with it, and then you risk them being able to spread it around to others. And so in those cases there, if I can just give them a shot in the ER and then I know they're treated, I don't have to really worry about them potentially having further spread there. So that's something that is good about some of these treatments here. Now, because gonorrhea and chlamydia typically go hand in hand in a lot of cases, it's usually recommended to go ahead and treat both at the same time. So in those cases there, it's not uncommon to see the panel, and you'll see this too, like if you were to work on an EMR, you'll see that the two will oftentimes come in the same sort of order set together, where you order the two at the same time. So they get a IM dose of rosafen for the gonorrhea, and then they'll get a 1 gram dose of PO azithromycin at the same time for the chlamydial co-infection that they may or may not have. As an alternative, you could do something like doxycycline twice daily for 7 days, although again, that's not ideal from a compliance sort of standpoint there. If a patient could not get rosafen, again, try to ensure that they really do have a true blue cephalosporin allergy. Oftentimes people say that when they really don't, either due to just not understanding what allergies really are, or being told that when they were young, something like that. So maybe some like things like IM gentamicin, jimifloxacin, which is a type of fluoroquinolone, but nothing that is as big of a slam dunk as Rocephin is. So that's why we like to stick with that. If we had an infant that had potentially, gonococcal infection in the eyes because maybe they picked it up from the birth canal while being born, we can use topical erythromycin ointment, and that's actually a really good treatment for that. Is able to have good activity, and again, it gets really high concentrations when it's right there on the eyes. So that's the treatment choice for that. With chlamydia, this is the second most frequently reported STD besides or behind HPV, which we'll talk about a little bit more later on. And so again, the issue here as well is because a lot of people are asymptomatic, that it's probably underreported. If anything, it's probably twice what the actual rates are, because a lot of people have it and don't even know it. Again, we like to use 1 gram azithromycin once, and that's a great way to treat that and be kind of one and done sort of treatment. As an alternative, as I mentioned, doxycycline may be used there. Fluoroquinolones may be used. And again, just be cautious with things like, tetracyclines in pregnancy. You probably want to avoid that. This is another case where oral erythromycin may be utilized for infants who maybe pick this up from the birth canal. No, really, 1 gram of azithromycin is kind of just what we go with there. Yeah, by getting the combo though, you certainly get good coverage for both of those. So I wouldn't necessarily go. And again, I'm trying to think. Maybe a couple of cases where you use bigger doses of azithromycin, but that's what's just recommended there. So I'd say just go with that, and you're good to go. In terms of syphilis, this is caused by a spirochete, the Treponema pallidum. And again, you can see here, this is a pretty highly contagious disease here. You can see in the men who have sex with men population, it can spread quite easily. And again, the big issues here, you worry about it being progressing into these really disabling or fatal cases here. So if they develop things like neurosyphilis, it can be quite deadly. Interestingly enough, the treatment here is actually penicillin G. And there's not a lot of things out there where penicillin is the treatment of choice, but you'll basically find that this is retained activity for many, many years now. And unfortunately with this one, because the Treponema pallidum kind of reproduces relatively slowly, you're going to find that just like a single dose therapy, if anything, won't really be effective here. So we can try things like using long-acting penicillin forms. And so this is that benzathine penicillin G, or bicillin. It comes, remember I showed you a picture, I think probably back in the summer or in the fall, of that kind of like white milky sort of penicillin formulation. That's sort of an oil base that goes into the muscle and kind of slowly releases penicillin over the course of many days, and that allows for just a single treatment. Even though the drug is working for longer than just a single day, you only need the 1 dose, which is good. If they could not receive penicillin, then doxycycline or tetracycline. And notice here that the treatment duration is like 2 to 4 weeks, so not really ideal from that standpoint. It does take quite a while to manage there. For more advanced cases, or more systemic cases, we may have to give things like continuous penicillin G infusions. This is more for your like really severe patients, probably going to be in the ICU if anything. Let's see. Someone had a question going back. I was looking over the genotype phenotype concept. I'm having a hard time understanding. How can they help with resistance testing? Yeah, I'm going to re-explain. Let me go back to that at the end. I think that'll be probably fine. And then genital herpes, this is certainly something that is quite common. We know that HSV 1 and 2 are mainly going to be the primary culprits here. HSV 1 typically seen with more oropharyngeal disease, HSV 2 with more genital disease, but certainly they can switch. That is not unheard of for sure. And again, just a huge number of asymptomatic people out there. And even without having like active lesions, you can still see viral shedding. So this is kind of a big issue there. And so it's really important to try to identify those people who may have it, and then educate them in terms of controlling the spread, because it's one of those things that's going to be sticking around for pretty much the long term. So our goals here, so when someone has a known case of genital herpes, we'd like to be able to relieve their symptoms, because it can be quite painful and uncomfortable, and try to shorten the clinical course, and then try to prevent any kind of complications from occurring. And if you can reduce the overall number of episodes, that's also good from both a disease transmission standpoint and just from a patient quality of life standpoint there. For the pain and discomfort they're experiencing, we don't have anything really specific to treat that, other than things like analgesics and antipyretics. If it's particularly itchy, you can try using something like using something like an antihistamine or something like that. Again, you want to be careful, make sure they're using good hygiene, because you can get secondary bacterial infections due to that having that that impaired skin barrier basically there. So that would be recommended. Ellie's saying in ClinMed we learned about the Jerish Herxheimer reaction following syphilis treatment. Would this be indication to stop treatment or keep going similarly to Iris? That's a good question. I don't know specifically about that. Let me see here. Let's see, treatment. You guys probably enjoy it when I Google it. It doesn't seem like something you necessarily stop treatment for, at least from quick thing here. It doesn't look like there's any specific treatment for it. Yeah, so I don't see anything specifically that says that you should stop treatment. It sounds like it's pretty self-limited for the most part and should resolve within 24 hours. So, yeah, I don't see anything specific. But if you find something different, let me know. We can talk about that for sure. That's a good question. That's the first time I've ever been asked that question. I've not seen that before. Anyway, so in terms of like treatment for genital herpes here, we're going to see the CDC recommends antiviral therapy. Typically, this will include either something like acyclovir or valcyclovir. Famciclovir I've not seen used too often here, but we've talked about these before back in the infectious disease section back in Bugs and Drugs, many moons ago. But basically, you'll start them on a 7 to 10 day course, and this is good because it helps to reduce the duration of symptoms, helps with healing time, and also reduces that viral shedding such that they may not be able to pass it on to someone else quite as easily there. The main thing you're going to see here, and this kind of goes the same with most viral infections, is the sooner you can treat it, the more effective it's going to be. And it seems like a no-duh sort of thing there. But if they can get treatment, and oftentimes you may have patients who have recurrent episodes, you'll have them or give them a prescription that they fill when they know that they're about to have an onset. Either they see it, they feel it, and they sometimes have prodromal symptoms where they will know an episode's about to come on. Have them go and start treating it early, because the longer you wait, the less effective the treatment's going to be there. And so you might as well not even do it after a certain point. And so, again, receiving treatment should help to prevent those prolonged symptoms, at least for the first treatment here. Using topical acyclovir would not be recommended. It needs to be systemically administered, so oral. And then if those that are immunocompromised, they tend to be at risk for developing more severe systemic disease. You can see things like hepatic encephalitis and things like that. At that point there, we have to use IV acyclovir. Now, of course, with acyclovir, it's certainly not without side effects, but the IV form tends to be a lot worse in terms of causing renal issues. You can see things like bone marrow suppression, CNS toxicity. So you can prevent them from getting to that point where they need IV acyclovir. That is always going to be beneficial. For recurrent infections, there's kind of two ways you can do this. You could either do episodic therapy, where if they start to have symptoms, they can initiate therapy within 6 to 12 hours. No more than 24 hours after lesions appeared, because again, you're going to be losing that efficacy as time goes on. This is better for patients who have more like kind of severe symptoms. But again, even if they are having no symptoms whatsoever and they're not on therapy, they still may be shedding virus. Okay, they can still spread it to others. On the other hand, you could also do chronic suppressive therapy as an alternative here. And this basically will help with patients who are having kind of multiple episodes per year, and can reduce those by about 70 to 80%, which is pretty good. And you will see that this will have less asymptomatic viral shedding. Again, what that's really going to do to the spread rate to other individuals, we probably don't know the full details on that, because again, it's difficult to even know the real incidence of genital herpes for the most part. But this is something that I see a lot of patients do use, because again, it helps, especially if they're sexually active with a serodiscordant partner. This can help to prevent the spread to them, which is good. Another case here of trichomoniasis. This is caused by another protozoa here. You can see several million cases per year. And this is something that, again, is more commonly reported in females, which is kind of a bummer, because I feel like a lot of these things, tend to be more pronounced in females. Males tend to be more asymptomatic for a lot of these conditions here. And men can just have a spontaneous cure rate that's higher than women. Not only that, but it's also easier to spread from man to woman, which is not great. So again, you guys are kind of, female patients are starting getting the short end of the stick there from that standpoint. Main treatment, though, is going to be metronidazole or Flagyl. So you guys remember that. Remember not to be drinking with Flagyl, obviously, because of the disulfiram reaction, and then tinidazole, which is another antiprotozoal drug, sort of in the same category as metronidazole, may be useful here as well. Basically, just do a 2-gram dose of either, and that can be just a single one and done sort of treatment there, which is handy. Again, this is a case where treating the partner also leads to better cure rate, because if you were, say, treating a female patient, get a male partner, you treat her, then maybe the male still has it as asymptomatic and give it right back to the female partner, right? So sometimes by giving, and again, the law supports this, to be able to write for prescriptions for some of these to the patient's partner that you've never laid eyes on. You could write a prescription for them for treatment in order to prevent them from having further spread. So again, there are some legal allowances for that, being able to write for a prescription for someone you've not personally seen. Now switching gears and talking about hepatitis. Again, this goes all in the same sort of basket in terms of, like, sexually transmitted diseases, things that can be spread through, like, needle sharing and things like that. So there's 3 main types of hepatitis we'll talk about today. So A, B, and C. We'll see that in terms of treatment, we're going to see kind of the most new things with hepatitis C here in just a little bit. But starting off with hepatitis A, this is typically a pretty self-limiting thing for the most part. You'll find most people are vaccinated, especially newer individuals onto Earth have been vaccinated for the most part. And so we're certainly seeing a decreased incidence there. The big thing you'll see here is this fecal-oral transmission is a common source for infection. So things like contaminated water, things like that. And actually recently in past years, probably within the past 2 or 3 years, Florida had like a really big outbreak of hepatitis A as sort of a epidemic sort of thing that's happening there. Christina's asking, when would you use tinidazole over flagyl? I don't know that any one is particularly more effective than the other. I usually see flagyl being used. It might be just based off the formulary for wherever you're working, because again, that'd be one of those things where if you can give it to them right in the office or in the ER, that would be the best treatment, because you can actually see them take it. Then give them a script for their partner or something like that. So whatever's cheaper, I think flagyl is probably going to be cheaper most of the time there. So anyway, so again, you can see here that usually the infection is pretty self-limiting, also confers immunity, which is good, so that way they don't get it a second time. Most people will resolve within about 6 months or so. Most people within 2 months, which is good. And then you're going to see here that once they are kind of resolving, they should have normalization of the liver function, decreased transmission, because again, they should be immune at that point there. And you're going to see that the best way to prevent this is obviously going to be the vaccine. So for instance, we recommend children at 12 months end up getting this. And so a couple of different varieties, things like Havrix and Vacta. Don't memorize the brand name specifically. Just know that we have a vaccine that's available for hepatitis A, and usually kids are going to be getting this around 12 months or so. Obviously, the biggest thing that can be used to prevent this is just washing hands. If you're changing diapers, making sure you're washing your hands really thoroughly after that, especially if you're going from like changing diapers to food prep, which sounds like ridiculous. Like, why would anyone ever go from changing diapers to food prep? You have children, that's not an uncommon occurrence there. So washing your hands is always very, very important. If a patient needed some sort of post-exposure prophylaxis, you may see this being done if you have patients at the really severe extremes of age, either old or young, or if they're immunocompromised, you might require something like an immune globulin that is targeted against hepatitis A, although this is pretty uncommon. You're going to see this being utilized, but it is available in some rare cases. Hepatitis B is actually quite infectious, even more so than HIV, about 50 to 100 times more infectious, so very easy to spread here. And again, you're going to see that this is a big reason for things like cirrhosis and hepatocellular carcinoma. So if we can, again, prevent these infections, that's always going to be very, very important here. And again, you can see this can spread sexually, can spread parenterally. So if you're sharing needles amongst IV drug users, perinatally, so from mom to baby, things like that. And you can see here that while some people will recover on their own, that may not always be the case there, and may develop this more latent infection. You'll see this especially with like more perinatal infections. You can see that it becomes more kind of chronic. We do have an HPV vaccine, which is good. This is actually kind of the first vaccine we have to prevent an actual cancer, right? So I think a lot of people think about the HPV vaccine against cervical cancer, but this is a case here. We actually have a vaccine that's very effective at preventing liver cancer, right? You're going to see here that most patients will end up getting vaccinated, especially newer patients have been recently born. So things like Intergix B or Recombavax. You'll see here that we have a Twinrix, which actually has treatment for hepatitis A and B, which is can be helpful there to cover for both. And then for some patients, we may require immune globulin in order to treat that if they're, again, very immunocompromised or extremes of age where they may have a compromised immune system there. With the vaccine for hepatitis B, though, you're typically going to see the response is relatively low, and so this is where you may need multiple doses in order to get kind of an optimal response. A lot of times, if you go to work at a new health institution, they will check titers for your HBV antibodies, and if you're low, they may give you a booster shot. So you may see that done occasionally as well. I think I had to get one like when I started at Nemours or something. I said, "Oh, your antibodies are too low. Let's give you a little booster," and then that pops it back up, and then you're protected again. So again, if we have someone who is not able to clear this and they develop a more chronic infection here, we want to make sure that we're trying to suppress their viral replication. And if we can try to get them to seroconvert to where if they're normally presenting the antigen showing the HPV is there, and have them then produce the antibody, so the hepatitis B envelope antigen. And then obviously we want to prevent them from developing more chronic hepatic sort of complications there. Basically, a lot of patients will do a more watchful waiting sort of approach to see if their body can clear it on its own. And so you may just do serial hepatic function monitoring along with the serological markers to see if they can convert on their own. And then if they do start to see things like their LT start to pop up, and then the risk of things like liver-related morbidity goes up, then you go ahead and just initiate treatment at that point. So here's how this would kind of go. You can see here that you're looking at things like the actual HPV DNA. You're looking at the actual antigen itself, and then you're looking to see, okay, well, what's happening with the LFTs? The ALT starts to bump up above their 2 times upper limit of normal. Then you go ahead and initiate treatment here, which I'll talk about the drugs more specifically. Obviously, if they come in and they're decompensating or they have jaundice, and you go ahead and treat at that point there. Otherwise, you can just kind of monitor and see how they do. So let's talk about a few drugs that you can use to treat hepatitis B. Some of these will have some crossover with hepatitis C, so that will be beneficial and kind of getting 2 birds with 1 stone here. First off, we have interferon alpha, and I think we might have talked about this briefly in the oncology section, I think. But basically, this was shown to help out with outcomes, shown to help out with approval with survival, and basically it acts as like a host cytokine, so it kind of stimulates your own immune system to try to attack the hepatitis B. And so you can see here has anti-proliferative actions, has antiviral actions, and so again, you can use it for a wide number of things. So not just hepatitis B, but as I mentioned, for certain types of cancers, you may see this as well. This is a pretty nasty set of drugs here with the interferons because, again, you're stimulating your own immune system, so you're not going to be feeling good while taking this because you're going to be more inflamed than you otherwise would be. And is a protein, so you have to inject it 3 times weekly. Some of them will have a little bit longer half-lives, like this pegylated form of it that is given just weekly. Some of that may help with the efficacy and decrease the number of injections they're requiring. Overall, these are very expensive, and the side effect profile is really just awful. So as an example here, you can see things like hepatic decompensation. The really big thing you worry about, especially the black box warning, are these neuropsychiatric events. If someone has like a history of depression, this can worsen that, as it led to suicide in some cases. People get really kind of aggressive or just kind of really anxious and things like that when they're taking this drug. They just really don't feel well while taking it. Their mood definitely takes a nosedive there. You're going to get a lot of flu-like symptoms. And also there's risk for anaphylaxis, so it's just not a great drug from that standpoint. But again, on the flip side, if you're going to die from hepatitis B versus this, then, you probably would say this is the better option there. And again, some patients may require treatment for up to like 24 months. And so this is really expensive. It may be very difficult for patients to be able to be compliant here with this, especially when they feel so miserable while they're taking it. So if you can prevent this, especially by doing things like getting vaccinated, that can be really helpful there. Other options we have include things like lamivudine, which we saw previously in treatment for HIV, so some crossover here in terms of antiviral activity. Here you're going to see some resistance being a problem, so it's not recommended as first line. Another drug called adefovir or Hepsera is kind of similar mechanism to lamivudine, so it's an NRTI sort of drug there, and is good against patients who maybe have like resistant HPV that is not going to work with lamivudine. So that could be one option there. Here you do want to watch for renal function because it can harm the kidneys, so I would want to watch BUN, serum creatinine, things like that. Other options we have here include things like entecavir. This is again used for lamivudine resistant strains and is pretty similar in terms of safety profile there to lamivudine. Nowadays, this is starting to become more first line due to lower resistance issues, which is good. And also, it's an oral agent, which is kind of beneficial from that standpoint. And other ones you might see occasionally include things like telbivudine and tenofovir. So just kind of be aware of like kind of what drugs can be used for specific treatments here. So for instance, if I put like a protease inhibitor on here to treat Hep B as a test option, that would not be a good option here. You want to know specifically what drugs can be used for which sort of disease states there. For Hep C, so this is the biggest one that's had the biggest changes here. Now, there's no vaccine for hepatitis C currently in production, and this used to be sort of like a lifelong illness people dealt with. And again, the drug therapy we have available was not great. And again, you're gonna see interferon pop up here again. But now, within the past couple of years, we've seen a big revolution in terms of treatment, and we have seen now that we can have actual cure for hepatitis C with some of our drug options, and so I'll get into those here. Again, most acute cases do go on to become chronic because your host immune system just isn't enough to really attack it there. So Christine's asking, is interferon alpha ramping up the immune system? Why are you at risk for infections? Basically, you can end up seeing that, kind of ramping up your immune system that much, in my mind, I like to think about it as kind of like, you're getting it so aggressive that you kind of wear itself out a little bit to where it can be coming at risk for certain other types of infections. But also think about you're injecting a drug into the skin, so maybe they're at risk for things like skin infections, so those would be things that I think of most likely. You're not going to see like immunosuppression specifically with that, but you can be at risk for just other types of infections. So that's kind of how I think about it. It's probably not the most common thing I would think of. More often than not, it's really like the mental status changes you see there, risk for like anaphylaxis, the flu-like symptoms. Those are the big things I think about with interferon. Obviously, with hepatitis C, if we can eradicate the infection, that's always going to be recommended. And basically, what we'll do is we're looking for this sustained virologic response, where you cannot measure the HCV RNA for at least 12 weeks after the end of treatment there. And again, we want to prevent them from progressing on to end-stage liver disease, if at all possible there. And here in this case here, as opposed to like HBV, where you could do like maybe watchful waiting to see if the patient can clear it on their own, in this case here, you actually want to go ahead and just start treatment, and then we'll figure out once we do some resistance testing whether or not we need to go for longer or shorter treatments. And so I'll talk more about that as we get into the drugs. So as I mentioned, this previously required interferon therapy, so a ton of side effects. It required another drug we'll talk about later called ribavirin, which is also not great. But nowadays, our standard is going to be this all-oral regimen of either 12 or 24 weeks. And we're going to see here, this will really depend on the genotype of the HCV. So there's 6 different varieties here, and there's some subtypes there. But you're going to see that the most common ones in the US are GT1A and 1B. This will become important in a couple of cases. We'll see some of the drugs, the newer drugs we have, maybe a more broad spectrum. They treat kind of all varieties. Some of them may be more specific. And so we'll talk about those as we get into them. So this is huge. So we have now this new class called the direct-acting antivirals. And so basically, if you can imagine, what the proteins look like here of the HCV virus, right? So these are the different protein components that it's forming in order to make new viral RNA they can then send off and infect other cells, right? And we're going to see here that our drugs can come in and try to inhibit different portions of this to try to make sure that we don't have any kind of functional new HCV being made here. So again, as opposed to giving them a drug that just tries to ramp up your own immune system and try to attack everything, sort of without any kind of real direction, here we have things that are directly specific for the HCV, and so this is what we're going to be looking at here. So I will say these drugs are particularly difficult to say. They just don't have a lot of easy to say syllables all linked together. But first here we have this drug called the cladosphere, which is effective against GT1 and 3. For testing purposes, I'm not going to get real specific and say which one goes against GT1, which one goes against GT. I'm not going to get that specific. You can look that stuff up, right? Again, I'd rather be familiar with the drugs, kind of know what they're used for, know what kind of, if there's any side effects to look for, and things like that I want you to be able to identify. You're going to have a hard enough time anyway with this set of drugs just because you see something with a VIR. You don't know if it's for HIV, you don't know if it's for hepatitis. It gets confusing. So again, I'd rather be able to recognize, okay, this drug is used for hepatitis C. What do I know about this drug? What does it do? What's its mechanism? Are there any side effects to look for? Are there any drug interactions? Those are the kind of things I want you to be able to focus on for this, for testing purposes. Don't get too hung up on the specific subtypes there, because I'm not going to ask that question. Okay. Anyway, so what does this do? Well, basically, it's going to prevent the viral RNA replication because it's going to be binding to the NS5A protein. And so basically, it will distort the structure of the protein, prevent it from really working. So as you can see here, by blocking this NS5A, you're not able to form new viral RNA. It's just inhibited. You cannot form that anymore. Okay. So you arrest the replication of the virus. And again, these are really good drugs from the standpoint that they're oral. They don't cause a lot of side effects like you would see with interferon. And you're done in 12 to 24 weeks, which is awesome, because before this was like a lifelong disease for patients, and now they can get rid of it in 3 to 6 months. That's fantastic. And again, not a ton of drug interactions, not a ton of issues you can see here. The downside is real expensive. However, the price for treating treating a patient for this and clearing them of their HCV is a heck of a lot less than hospital stays and liver transplant, things like that. So in the end, it probably behooves insurance companies to probably pay for this stuff. Next, we have a combination called Harvoni, which is ledapasphere and sofosbuvir. Again, these are syllables that I don't like to say all together because they're difficult to say. But here you can see this works on a wide variety of the different subtypes of HCV, so 1, 4, 5, and 6. Here you're going to find that ledapasphere is going to be an NS5A protein inhibitor, similar to what we saw on the cladosphere on this past one. Sofosbuvir, although it's going to be a prodrug, is actually going to inhibit the NS5B RNA polymerase. So basically, it's going to act as a chain terminator, kind of similar to what we saw with the NRTIs back in treatment for HIV. And once it gets incorporated into the viral RNA, it prevents it from being able to add on any other nucleotides to that. You can see some synergy here between the two, where one's preventing the protein from causing the virus to replicate the RNA, and then here you can see that the RNA itself is being attacked by the sofosbuvir. You may see that sofosbuvir by itself, and then it can be used in combination with other drugs there. But again, quite expensive. Here you can see there's either between $27,000 and $30,000 per month. Again, multiply that by 3 to 6 months, you can see that the price adds up pretty quickly. You could probably buy a pretty nice car for as an alternative. However, then you still have HCV, and that would not be great. So, and again, this is why it's important to impress upon the patients, like, why compliance is so important, is because if they're not going to be compliant, you can see resistance that can develop here. And so again, not only is it a huge cost, which hopefully the patient's not footing the bill, hopefully the insurance will get most of this, but that if they're not going to stick with it, they're just going to get resistant, and that drug's not going to work for them, and they may be stuck with that infection the rest of their life, right? So you get to find different ways to impress upon people, whether through cost or whether through other mechanisms, to say, hey, this is really important. You need to be compliant with this. Otherwise, we're going to have some problems here, right? So then you have Simprovir, Alyssia. This actually inhibits a different protease. So this NS3-4A protease. Basically, if you were to look back on this slide back here, you see here the kind of immature virus, which is basically several proteins all kind of been formed through things like translation, but it's not mature yet. It hasn't been chopped up by a protease to form the more active components here, right? So basically, by giving something like Simprovir, it inhibits that protease from chopping up that protein into more of the functional components there. So basically, you can't make the NS5A, you can't make all of those proteins that are necessary to make a functional HCV, right? So good from that standpoint. In terms of adverse reactions, again, relatively mild compared especially to things like interferon. May see some photosensitivity or skin reactions to note. Again, also quite expensive. And here's not one you would not want to use by itself, but typically might be added on to things like sofosbuvir plus interferon or ribavirin therapy. We'll talk about ribavirin here in just a few moments. We have ombutasphere, which is another NS5A inhibitor, similar to like cladosphere as an example. And this is typically given in combination with other drugs. So again, combo therapy is typically the rule here. So here's one called paritaprevir, which may be given with, which is another NS3/4A inhibitor. You may give it with ritonavir. So you can see here that this will actually boost levels of the paritaprevir. So you can kind of get the triple combination here. We're utilizing drug interactions for our own purposes to try to boost levels of other drugs. Or you can give the ombutasphere with disabivir. And you can see a combination with the other three above called, so there's different brand names that are out there for different combinations. And so a lot of this is going to be decided based off the subtype of the HCV that they have, along with some other things we're going to look at in terms of consideration of which drug we're going to be using specifically. So, and then the other kind of old school drug we used to use a lot more for HCV is a drug called ribavirin. Again, this is something we see ribavirin plus interferon used. That was kind of the gold standard for a long time for HCV treatment. Basically, we don't really know fully why it works. Probably something to do with affecting things like guanosine triphosphate. It also has some immunostimulatory reactions, and then cause a lot of RNA mutations, leading to sort of what they call an error catastrophe, which I feel like probably describes my life in a lot of cases. It basically causes so much errors in terms of RNA that it just causes apoptosis. It just cannot continue on with that particular strain of RNA. And so you're going to see here that this was given all the time with the interferon back in the past, but the adverse reactions were really severe, especially in combo with interferon. So things like suicide ideation, depression. I knew some people who family who had to deal with HCV. One of the partners there had HCV, and they talked about being on ribavirin therapy and interferon. It was just like you just knew for that course, that couple of weeks, you just couldn't be around them because they're just such an angry. They're just kind of a jerk the whole time, and it wasn't their fault. It was the medications that they were on. And so again, it was one of those things where they just they had ribavirin brains, just like don't even bother with them because they're just gonna be cranky. This is another drug that you can see you would not want to give to pregnant patients. And actually, interestingly enough, they recommend using 2 forms of birth control up to 6 months after discontinuation, because there could be some drug around that could still affect a developing fetus. So one of those things where, again, if you had a patient who wanted to become pregnant, like this could be a serious consideration if they had to be on ribavirin. So basically, in terms of like treatment tips, you're going to see here that ribavirin is still used occasionally, but typically more difficult to treat patients, especially those that have been on prior treatment that may have resistant disease or if they have underlying cirrhosis. Occasionally use interferon, especially that has gone down pretty significantly since the direct-acting antivirals have now come out. They don't see that too often anymore, which is good. And then for patients with cirrhosis, maybe they've been dealing with this for a long time, they have a hard time getting good sustained response here, and so you may need to adjust which drugs you're giving. You may need to adjust the dose, or you may need to give it with things like ribavirin potentially. So I'll show you a table here just a little bit to see kind of what the different treatment options may look like. Typically, if they're treatment experienced patients, they've been on things before, they typically require longer treatment or the addition of ribavirin. So they may be on it for 24 months instead of 12 months. Then you can consider doing the resistance testing as well to see, okay, well, what's going on here? Why are our drugs not working? For many patients who have, exposure to HCV, you may wait 6 months before you decide to treat, since about half of people will be able to clear it spontaneously. Other people may consider, especially if they're at risk, if they have other immunocompromised disease states like HIV, you may just go ahead and treat right away. Just depends. But in terms of compliance, as I mentioned, any delay can lead to resistance and failure of those drugs. And again, we didn't have too many options there. So you have to make sure patients are receiving their medication every single month. So this may be a case where you have them come back to you every single month to get a new script to make sure they're being compliant, making sure everything's looking good before you decide to give them that next month's worth, right? So just to give you an example, and again, I'm not going to have you memorize this for testing purposes. I'm just trying to impress upon you sort of the considerations that go into it and sort of the differences in terms of treatment durations and things like that. So as an example, if you were to test the patient's HCV and find out it's the 1A genotype, you can go ahead and look at it and say, okay, well, if they have no cirrhosis, and you get away with like 12-week treatments of relatively simple regimens here. Whereas if they did have cirrhosis, you notice we're adding on things like ribavirin. We're also treating for 24 weeks. That makes a really big difference in terms of your treatment. And then note that the genotype does matter because certain drugs will only be effective for certain different genotypes, basically. So those are kind of things that I want you to take away from that. It can just be where the serious, interactions, side effects, adverse reactions, things like that are kind of the takeaways I want you to get from that section there. So any questions on that? So someone was asking about genotypic versus phenotypic testing here. Basically what this means, again, I'm going to start the next lecture, so don't feel like you're getting off that early today. Basically, when you're looking at it, Matt is asking, do all NS5A inhibitors cause the patient to develop resistance? Is there anaphylactic reaction with this drug class? They can cause resistance by basically, they cause resistance if you were taking it for a while, but then you stop taking it. Like maybe you weren't taking it every single day like you're supposed to. That's where you can see resistance that can develop, and that's with any of them, right? So that's why you want to ensure compliance there. You may see anaphylactic reaction, but it's very low risk as compared to something like interferon or ribavirin, which are proteins that have to be injected. So I would not be as big of a concern with those as same concern to have someone have an anaphylactic reaction to Tylenol. Yeah, does it happen? Yeah, but probably very unlikely. See, Christina's asking, I'm a little confused about indications for the direct-acting antivirals. So basically, you have someone who you suspect has HCV, you test them, it's positive, they have it, and you get their genotype and all that. If you wanted to, you could maybe wait 6 months to see if they clear, especially if it's like a new infection, like maybe, you had a pretty good idea of the timeline of how they got the infection, and you can wait 6 months to see if they clear it on their own. If it's like an unknown duration, or if it's been more than 6 months, you can say, yeah, let's go ahead and start treating, and you just go with it. So in that case there, you just go ahead and treat. So the indications are pretty straightforward, I think, from that standpoint. Okay, so someone's asking about genotypic and phenotypic testing here, the concept. So remember, the genotype, if you take a strain of HIV, or take a HIV virus molecule, not a molecule, but a virus, and you were to take its RNA, you basically sequence it out, and you get the genotype, and say, okay, these are the amino acid sequence of its RNA, and this is the genotype of it, right? Basically what I can do is, based on that sequence and certain sequences that pop up, it will tell me, okay, well, because it has this mutation, it means it's probably resistant to this set of drugs. Again, this is just a educated guess based on the amino acid sequence that we're seeing there, right? Now, if you were to then actually, and again, it gets very complicated because you have multiple different mutations altogether, and sometimes you don't know specifically what that's going to do in real life, in vivo, for the patient there. But it gives you a pretty good idea. That way, if I see certain mutations, I'm going to say, okay, this drug is not going to be effective. It's going to be resistant. I'm not even going to bother with it. Okay. But again, it's not going to be exact for what's going to work for your particular patient when you actually give the drug to them. Okay. But it's pretty good. It's a good starting point. So that's genotypic testing. Phenotypic testing is where you're actually looking to see, okay, well, once I put all these mutations together, what actually happens in real life? And that's where you're going to be doing more similar testing to what you would see with like a bacteria when you do cultures and sensitivities. You're actually going to culture out the virus, and you're going to be able to expose it to different drugs to see really what it's resistant to, what it's susceptible to. The phenotypic testing has more utility, has more use for your patients to know whether they're going to be resistant for this versus this. However, it's more expensive, more time consuming. It's not done kind of first line. Maybe it would be done if you put a patient on a standard regimen based off their genotypic testing, and they come back and their RNA load, or their viral RNA is still high, and the CD4 count's coming down. Then in those cases there, maybe you want to try out the phenotypic testing. So that's kind of the trade-off between those two, and hopefully that makes sense. Otherwise, let me know, and I can go back over that more detail there. Or maybe less detail, but maybe more clear. Because I think it's sometimes what we get into issues with. Sometimes we might get in the weeds and kind of lose the forest for the trees there a little bit. Anyway, so I've got about 40 minutes or so. So let's see what I can get through in terms of talking about special populations. Whatever I get through today is going to be the end of our testing material. So just FYI for that. So let's talk about pediatrics first, briefly. I like to kind of go over this a little bit in the summertime before we know really anything about drugs, and then kind of recontextualize it now that we have more info, we have more context for the different types of drugs, how we're using them, and then we can kind of focus it in terms of seeing how they work in these types of patients here. So again, when you're looking at like pediatrics, like why is it so different? Why are they such a different beast? And like why are people so like people get really apprehensive when you think about treating, especially like adult patients or like adult providers. They get really nervous when treating kids because they're like, oh, they're so sensitive, they're so different, you know. And honestly, it's not really that difficult once you get used to it. It's just it can be really kind of daunting at first if you're not you've never done it before, right? Just like anything. But the issue is they're so heterogeneous, right? So you know, a 1 day old is much different than a 1 year old, which is much different than a 10 year old. And so because they go through so many changes, physiologically speaking, you can find that there's a lot of differences in terms of the pharmacokinetics and dynamics in these different patient populations. And then we don't have as much studies to show this because it's a at-risk, you know, population. It's harder to do studies that are, you know, ethical in that patient population. You can't do a lot of randomized controlled trials, right? Um, just recall when we're talking about the pediatric sort of lingo here. Frequently, when you're dosing drugs, especially for like infants and neonates, that you're going to be looking at things like the gestational age and then the postnatal age. Okay, so when you're looking at dosing for gentamicin for a neonate, you're looking to see like, okay, how long do they gestate for, and then how old are they now that they've come out of mom? Because those two things will give you an idea in terms of how physiologically developed they are and how aggressive or less aggressive you need to be in terms of your drug dosing. There's post-conceptional age, which is the two together. We don't use that as often there, but you'll see that a lot, especially with like neonatal drug dosing or infant drug dosing. It'll say, okay, was the patient more or less than 32 weeks gestational age? And now that they're born, are they less than 1 week or more than 1 week? And it gets a little confusing, but if you just kind of read through it, if you know your patient's details, then you should be pretty clear. Again, anything less than 37 weeks we consider to be sort of preterm. Full term is at 37 to 42, and then anything post-term is more than 43. In terms of when I say like a newborn or a neonate, I'm just talking about the first 28 days of life, just the first month. And then an infant is really anything during that first year. So sometimes you'll hear me call a newborn an infant, which is not incorrect. But I would not want to call a 10-month-old a newborn. That would not be correct there. So all newborns and neonates are infants. Not all infants are newborns or neonates. That makes a sense. But this is specifically just that first month there. And again, that's an important delineation. As when you're seeing a lot of development of things like the kidneys and the liver and whatnot. And again, drug dosing can change very drastically during this short time frame versus once they're older than that, things tend to slow down to some degree. Again, toddlers in that 1 to 2 range, young child 2 to 5. You know, again, this gets less important as you kind of go on in age, especially when you start to get to the adolescence, because at a certain point they start to act more like adult patients would. And in fact, the general rule of thumb is that when you're looking at pediatric dosing, especially for your bigger kids, you never ever want to go above what the adult caps are. Okay, so for instance, if the adult dose for ibuprofen, the adult max is 800 milligrams Q6 hours, for instance. And I had an adolescent, let's say I had a linebacker football player who is 17 years old and he's 100 kilos. The normal dosing for kids for ibuprofen is 10 milligrams per kilogram. If I have someone who's 100 kilos, I give them 10 mg per kilo, I'm giving them a gram of ibuprofen every 6 hours. That's too much. That's over the adult max. You would not do that. You just cap them out at 800. So in general, cap people out at the adult maxes and don't go beyond that. Okay. Again, that can happen too. Just as an example, at Nemours, we have a contract, at least I don't know, I'm sure it's still the case, but it may have changed. But we have a contract with places like Disney to where if they have a lot of sport, or they did have a lot of sports tournaments maybe before COVID, and you'd have football players and cheerleaders and stuff coming in that were close to adult-sized patients, and so you have to take that into consideration in terms of your drug dosing. They may be a child, according to the law, but they may not physiologically be acting like one anymore. They'd be closer to an adult, especially as they get closer to 18, right? Anyway, so I like to focus on some of the developmentary changes you're going to see here and how that affects us dosing our medications, maybe choosing the medications we're going to use, things like that. And so I like to go talk about all the different kinetic aspects, so the A, D, M, and E, absorption, distribution, metabolism, excretion. Obviously, with absorption here, a lot of this is going to be dependent on the site that we're looking at. So whether we're dealing with the skin, whether dealing with the GI tract, things like that. But also the physiochemical properties of the drugs matter as well. How big is a molecule? Is it too big to cross over certain membranes? Just like oral vancomycin. Vancomycin is a very large molecule. If given orally, it can't cross the GI tract most of the time. Particle size, pH, and pKa are going to matter here as well. So these are things we may focus on in terms of determining how well a drug might get absorbed. Recall that gastric absorption is going to be dependent on how acidic the gastric contents are, and this can change depending on the age of the patient, and then also the gastric emptying time or the gastrointestinal transit time. So if you see GIT, that's what that's referring to. And again, they will differ greatly between infants and adults here. So looking at pH in terms of passive diffusion here, we're going to see that typically, especially in preterm infants, their stomach pH is going to be a lot higher because they were not born at a time where they were ready to start digesting food and things like that. So their acid production is not really ramped up yet. Not only that, but also they've been swallowing a lot of amniotic fluid passively, and so that will then neutralize out anything else for the first couple of days or so. So again, for even a full-term infant, they may be at a pH of 6 to 8 for the first couple of days until they've kind of washed a lot of that out. They're producing their own acid, and then now they can get down closer to what the normal sort of content would be. And you can see here they'll kind of peak up around about a week or so, and then by around a month they should be kind of getting closer to normal limits of what adults are producing. Again, by 3 months they're about normal. Why is this important? Well, because it affects the ionization state of drugs and whether or not they can be passively absorbed. So if you recall, like dissolves like. So if I'm in a case where the patient has a pH in the stomach that is 8, it's not going to absorb acidic drugs very well because it's going to be more in a charged state and it's not going to want to cross those membranes. On the other hand, if I give a basic drug, that decreases ionization and increases absorption. So maybe have an easier time getting that. That would lead to higher levels of that drug. Okay. If you need a review, you can go back and look at some of that back from our first semester together. I'm sure most of you kind of probably burned those lectures or deleted them or something like that. But again, this information is still relevant. You're also going to find that the gastrointestinal emptying time is going to be a lot shorter, especially for infants less than 6 months of age. And so anyone who's dealt with newborns, you'll know that they have a lot of frequent bowel movements, especially during the first couple of months of life. That's because they have really short transit times. They're moving things through quite quickly, and so that can affect drug absorption, right? So things are being shuttled through very quickly. They have less contact time with the GI tract, and thus can't be absorbed as well. That may lead to different in the levels of drugs you might get in the blood based off of how long that drug had in contact with the GI tract. Other things that can affect this, you're going to find things like congenital heart disease may decrease blood flow to the GI tracts. That'll slow down that transit time. Type of feeding, whether they're getting breast milk or they're getting formula, their gestational postnatal age, all of that can have big effects in terms of how quickly they're moving things through that GI tract. As I said, having shorter transit times means you're going to have less contact with absorptive surfaces. That's less absorption overall. And again, extended release preparations really aren't used in the infant sort of period because they just don't really have as much contact time and really don't get as much benefit as you might see in someone with like an adult style sort of GI tract there. Now let's look at extraoral drug absorption here. You can see that we'll look at some of the things like mucus permeability, we'll look at skin permeability, all of that. This will certainly be very different between neonates to infants to children for sure. When you're looking at intramuscular absorption, this can be dependent on a lot of things. So this can include the amount of blood actually being perfused to the area of injection, and also just that drug penetration through the capillaries. We're also going to see that the volume distribution is quite different for infants versus older kids and whatnot, especially with neonates. And that can be affecting how the kind of apparent volume that drug's being injected into anyway. The problem you're going to see with intramuscular injection for drugs for little ones like infants and neonates is that they may not be like moving around a whole lot, right? Especially with the neonate, they may just be sitting there kind of bundled up in a little can't think of the word anymore, like a little swaddle, and they're just not moving at all, right? So they're getting less muscle blood flow because it's not needed, and then you're also going to be seeing a lot more water in the muscles. They're kind of like big bags of water, as we'll see here in a little bit when we talk about distribution, and so they're just not going to have as much absorption of that. So the drug just may be sitting there in the muscle, not really doing anything until enough blood flow kind of comes by. So you're going to see a lot more slowed absorption as opposed to a kid who's more active and moving around a lot more, right? Not only that, they have a hard time kind of regulating their temperature as well as neonates, and so that kind of peripheral vasomotor instability can also lead to some variability and sort of inconsistency in their ability to absorb that drug very well. Now, rectal absorption is actually really good here. They have very thin membranes. You're going to get good absorption as possible, so we use a lot of like Tylenol suppository is probably the most common one you're going to see being used there for fever and analgesia. The downsides, though, you're going to see, and this is good education for like parents and whatnot, is the fact that because they have a lot of increased amplitude of rectal contractions, they will frequently sort of just eliminate it out right as you insert it in. So basically, you can insert the suppository. It takes time for it to melt as it gets to body temperature and allow it to absorb. But there'll be situations where parents will try to give a rectal suppository. They'll put the diaper back on, and then 5 minutes later, they hear the kid grunting, and they come back and the suppository is sitting there in the diaper. So sometimes you get to like kind of give it time for it to melt. So sometimes you kind of insert it and then hold their cheek shut for a little bit. That can kind of give you some opportunity for it to melt and absorb there, but that can be a challenge because they eliminate it out and you have the whole suppository sitting there in the diaper. It's obviously not going to be doing any good for the kid there. It just won't get absorbed at all. Other ways we can get drugs into patients include the intraosseous route of administration. This is really good if you have emergent need for IV medications, but you have, it can be difficult getting IVs started on these kids. Imagine too, like especially in the pre-hospital setting, having a 6-month-old infant in the back of an ambulance bouncing around, driving down the freeway, and then you have to try to get an IV started with little tiny veins. Not going to be very easy, and so we can use the intraosseous route of administration here. Here's one that I see used quite frequently in a lot of hospitals called the EZ-IO. Basically, it's a little hand drill. You can see here's a big thumbtack looking things here, and you'd pick a different size based off the size of the patient. And this basically allows for the needle to go right down to the marrow of the bone, and this kind of acts as like a non-compressible vein. So it's really, and again, anyway, I could do this probably, and be able to get some medications into a patient. So very low skill needed, as opposed to trying to start an IV for those little tiny veins there. Very good. You can give fluids through this. You can give pressors. I mean, you can run whole codes through just using the IO, which is very handy from that standpoint. Although don't give me an IO, I'd be more likely just to kind of play with it than actually treat the patient there. So that probably wouldn't be good. Looking at absorption through the skin or percutaneous absorption, this is also a really important thing because you can see that because these little ones have sort of an underdeveloped stratum corneum, they can really get good absorption here, right? So for instance, if you, and we haven't covered the endocrine stuff yet, but like as an example, if you use a product called betadine, which is a disinfectant that includes iodine, these kids can absorb enough of that to where it actually shuts down production of thyroid hormone for them. They can develop hypothyroidism, right? You can see cases where kids will develop seizures because they were given antihistamine lotions and they absorbed that and then got really anticholinergic, toxic. So you got to be really careful in making sure that you are avoiding utilizing the substances that may cause issues when absorbed through the skin. Even though an adult may not be able to absorb that, these kids may have a good ability to do that. So yeah, just be really careful with this. Remember, I think I told you guys the story about these kids that were testing positive for THC, even though the moms were not, and a lot of it had to do with the lotion they were using on these infants that was being absorbed into the systemic circulation that triggered the assay, even though the moms had no exposure to THC. But Madeline's asking, for patients with short gut syndrome, is there a way to slow down their gastric emptying time without increasing their constipation risk? Let's see here. I don't know anything specific. I'm trying to think if we do anything, because certainly I've seen plenty of kids with short gut syndrome that we're giving medications to. I mean, you could slow things down with like giving them like an anticholinergic, but I think you're right that that constipation risk is kind of the other option there. So I think from that standpoint, you may look at either adjusting your dose based on the fact they have that kind of increased speed of moving things through. But I don't know any specific drug dosing that I've seen that says, okay, for kids with short gut, do this. So I don't know that it's clinically that important. I think for some medication, you're going to find that they still may have enough contact time with the small intestine, they get absorbed just fine. But yeah, it's a good question. I've not thought about that specifically, and I've not seen anything, at least in my clinical practice, that has made us adjust doses or anything specifically. But you talk to a GI person and maybe they would give you a very specific answer or something, but nothing to my knowledge. Looking at distribution of drugs, obviously this is very, very different in especially very little children versus adolescents versus adults. We're going to see here the volume of distribution is going to be basically, again, the apparent volume that you're injecting this medication into that gives us basically our concentration that we get in the blood, right? So how far out are these drugs being distributed to the tissues versus how much are they staying in the bloodstream? So I know we've kind of alluded to this topic, all the time throughout these lectures here, but again, just to kind of reiterate what the actual concept is. When drugs with high volume distribution distribute out to the tissues, and so there's not a whole lot left in the bloodstream to actually measure, versus things with low volume distribution like to hang out and stay in the bloodstream. Usually more lipophilic things have a higher VD. Things that are more hydrophilic typically have a lower VD. This is not exactly the case, though, with these neonates and infants, as we're going to see here, though. And this is because of the changes you're going to see, especially in body fat and their total body water and things like that happen over the course of the first few months of life here. And so, as I mentioned, they're basically just big bags of water when they come out from the mom. And in fact, you'll see that a lot with kids that are first born. In the first couple of days, they will tend to diurese, and it's not uncommon for them to lose, a pound or two, maybe not a pound or two, but maybe at least a pound of just water weight. So it appears like, oh no, the kid's losing weight, but really it's just they're diuresing all this extra fluid because they're kind of puffy from being in the mom and being absorbed, around all this fluid for the past 9-10 months. And so because that volume distribution is so different for these kids, we have to make sure we're adjusting our doses effectively as well. So the issue here is they have limited muscle mass, they have less fat mass than you would see, and they also have a higher amount of body water, especially in that first month of life and the first couple of months. So what that's going to do for us is the fact that our hydrophilic medications are generally going to have a higher volume distribution in the neonate than it will have in, say, a 6-year-old versus an adult patient. Okay, because they have less fat, they have less muscle, and they have a lot more water for their weight per kilogram than you would see like with an adult patient. Other things that affect this are certain things like protein binding, fat solubility, like we kind of mentioned here, and certainly plenty of disease states where you can cause their volume of distribution to be affected, whether they're dehydrated, whether they're edematous, whatever the case may be. So as I mentioned, newborn infants, about 70 to 75% just water weight there, right? So a lot more extracellular water component than you would see with an adult patient there. So less fat, less muscle. And so again, this is why we dose so differently for certain drugs than others. We have to give a bigger milligram per kilogram amount to fill the same bucket and get the same concentration as we would for an adult. So especially for hydrophilic drugs, because again, more of that drug is getting out to the tissue as opposed to staying in the bloodstream where you're actually measuring the actual amount of drug there in the blood. As a practical example, here's gentamicin and how we dose this so differently. Again, you're giving like 4 to 5 times the dose for a neonate as you would for an adult patient on a milligram per kilogram basis. If you gave this amount, if you gave 4 mg per kilo to an adult patient at typical like Q8 hour dosing, they would become very toxic. They would have hearing loss and they'd have kidney dysfunction. So you can see here, this is all related to the differences in volume distribution. This is 2 or 3 times higher than for the adult patient. So you have to adjust the dose to account for that to get the same level in the blood. We don't measure tissue levels of the drug, we measure blood levels of the drug. That makes sense. So this is why it's really important when you go and look at something like Lexicomp, you'll notice there's a neonatal section, there's a pediatric section, and then there's the adult section. So if you're dealing with a neonate, make sure you look that up. I think it's not unheard of that you guys might be working in the NICU, for example. So you want to make sure you're using the correct resources to your dose and your patients correctly. We'll also see they also have decreased plasma proteins, especially for things like albumin that might be competing for certain binding sites as drugs. Remember, we can't give ceftriaxone or Rocephin that first month of life because it actually competes for the same binding sites as bilirubin. It can cause your patient to become jaundiced because now that ceftriaxone is binding to all the proteins, that bilirubin is just floating around, just kind of causing the patient to become jaundiced and icteric and all of that. Another example would be things like phenytoin, which we talked about back in the epilepsy section there. But basically, because less of it is being bound to proteins, there's a higher free fraction. With like in a typical adult patient, maybe 10% is free. But with these kids here, maybe it's 15, 20%. And that means that even though you may have the same level between an adult and a kid, they have a higher free fraction. They're going to be getting a lot more side effects from that. Maybe more efficacy, but more side effects as well. So you can see here just some of the changes between things like bilirubin, albumin, and all of that. Again, I'm not going to test you specifically on this, but just the concept is what I'm trying to illustrate here of why we might dose differently or why we might select different drugs for these particular types of patients, right? We'll see metabolism is going to be very different as well. Certainly, the liver comes out not fully formed and functional in terms of like the number and quality of the enzymes that it has. Not only that, but you have to contend with things like, things changing hepatic blood flow, like congenital heart disease. You have to worry about if you have drugs that are inducing or inhibiting our enzyme systems here. And so in some cases, you'll find kids may be more susceptible to certain types of toxicities because they cannot metabolize as well. In some cases, they're protected because they actually can metabolize more effectively than an adult patient might. I'll give you some examples of that. If you recall, phase 1 reactions are going to be things that are trying to modify a molecule to get it either ready for a phase 2 reaction or it's getting it ready for elimination through the kidneys. So most commonly we think about oxidation with the CYP P450 system. Certainly there are others like hydrolysis reduction, things like that, right? So as an example here, the CYP P450 system is going to be very pretty variable in the first couple of months of life, where you can see some things may be elevated above adult levels. Some things take a while to ramp up to get to adult levels. It's just very going to be on a case-by-case basis, and they can be per CYP enzyme. 3A4 may peak up at this time frame, whereas 2E1 takes longer. Very dependent on the case there, and that's when you're looking up your drug dosing for neonates, that's what they're taking into account for. They're taking into account that if the kid is this gestational age and this postnatal age, they should be metabolizing it like this. Okay, that's what they're taking into account. But examples, some things are overexpressed. So for instance, phenytoin dosing has to be elevated for 1-year-olds because they're metabolizing it 2 to 5 times faster than an adult might, right? So they need a bigger dose on a mg per kilo basis, so they may need it more quickly, or more often, I should say. Other things may not be able to metabolize as well. So for example, there's a drug called chlorohydrate. We used to use this a long time ago. If you ever heard the term slipping someone a Mickey, that means drugging their drink in order to do nefarious things like steal their wallet or something like that. The original product that was used for that was something called chlorohydrate. It's a very sedating sort of drug. We used to give it to kids a lot in like the PICU and the NICU because they could not metabolize it as quickly, and so it was a nice, really long-acting sedative agent. So if they had, something like neonatal abstinence syndrome where they're withdrawing from opioids that their mom was using during pregnancy, you could use this to really kind of chill them out. This is off the market now, but that was one example how we could utilize kinetics to our benefit there. As I mentioned, within a couple hours, CYP2E1 may increase rapidly, whereas things like 3A4 are present within the first month. Just know that they're going to be variable here, and again, your drug dosing needs to take into account what's happening here in terms of like the maturation of these CYP enzyme systems. And so, if something is underexpressed, especially in the first couple of months, you may find that you have to dose a drug less frequently. So for example, instead of giving it Q12 hours like you would for an adult, maybe only give it Q24 hours or Q36 hours for a neonate as an example. With phase 2 reactions, this is typically where we're adding on something to the drug in order to get it ready for biliary or kidney elimination. So things like sulfation, methylation, things like that. We're going to see phase 2 reactions, if you recall. This is another case here. We can find that some of these are really well expressed. And so, for instance, if I have a kid who ingested Tylenol. So I'd get this call at the Poison Center back in my fellowship a lot, where the parent would say, "Oh my gosh, little Johnny or little Susie got into an entire bottle of Tylenol. Are they going to die?" And oftentimes, even if they drank an entire bottle, it was not going to be a problem because for a kid to be potentially toxic from Tylenol, they'd have to get like 200 milligrams per kilogram. For an adult patient, they only need to get like 150 milligrams per kilogram. So I'd actually be sending an adult in with a lower mg per kilo amount of Tylenol to the hospital for treatment. I'd send them for a lower amount than I would for a kid because they're so well protected because their enzyme systems that metabolize acetaminophen are really good, right? Other things to consider too, things like glycine conjugation. This is a really important one for benzyl alcohol. If you ever work on the NICU, you're never going to see multi-dose vials being used for drugs. So when I talk about that, you may see vials of drugs. Some of them may say single use. A lot of them will say single use. Some of them may say multi-use. That we can go back in and get more medication of it later for maybe a different patient or something. Those multi-use vials are multi-use because they usually contain preservatives in order to keep it sterile, keep it stable. A lot of times that includes a drug called benzyl alcohol. Well, benzyl alcohol cannot be used in NICU patients because they cannot process the glycine conjugation, and they develop a really severe acidosis. They get what they call gasping syndrome, where these babies will just be gasping for air because their body detects that there's too much acid in there and trying to blow that off, and it just doesn't happen. So that's why that is contraindicated in kind of multi-use products. are usually just not going to be used in the NICU because of the fact that a lot of them do contain benzyl alcohol. That's just one example. That's a big medical error that happens from time to time for sure. In terms of excretion, again, this is going to be very dependent on the gestational and postnatal age of the patient in terms of how well developed their kidneys are in terms of being able to clear medications. This is a huge determinant on how often we're going to be giving drugs, whether we're giving them more or less frequently. In a lot of cases, for things that are heavily renally eliminated, we're going to be giving them less frequently, right? We're going to see less often of that. And again, remember that GFR is not accurate, especially in the first couple of months of life, because one, serum creatinine is falsely elevated because you're measuring the mom's serum creatinine that's equilibrated with their blood. And then two, we just don't have really good formulas to help us determine what the real renal function is. So oftentimes what we do instead, we'll look at their urine output. Urine output's really important here. Usually for kids, we'd like to see anything more than 1 ml per kilo per hour. That's considered to be sufficient urine output. If it's less than that, then we get concerned. For an adult, it's usually 0.5 to 1 ml per kilo per hour. So again, we expect these little ones to be urinating more volume than an adult would based on their weight there. But again, you can see here a lot of issues in terms of having decreased quantity and quality of the glomeruli. Renal tubules are immature, so a lot of issues there, especially with preterm infants, right? And again, you can look here at their renal function, actual GFR, if it was measured term infant versus preterm of various degrees there. Usually the more preterm you are, the less you weigh. Even by 2 weeks, the preterm infant who may be born a couple months early is not even caught up to the term infant there, right? So again, it takes them a lot of time to be able to catch up with that. That's why, again, you want to look at your drug dosing to make sure that you're taking into account their postnatal age and all of that. So to give you an example here, you can see how the GFR will change from a neonate all the way up to an adult. I like to focus on this example of gentamicin. So for instance, like the half-life here for a neonate, less than 1 week is like 3 to 11.5 hours. So pretty variable all the way up to adults. So like an adult patient may get gentamicin every 8 hours, whereas someone like a neonate may be getting every 24, 36, 48 hours. So let me bring that. I want to give you, I'll just show you a lexicomp here, and then just to kind of drive the point home, I think. We'll go gentamicin. Again, I'm going to the specific pediatric database here, so I hope you guys can see this. I'm going to try to... What's up? So when you're looking at the actual dosing here, so this is why I talk about when I'm saying that it gets very specific in terms of like both the gestational and the postnatal age. So you can see how one is broken up on the gestational age, so less than 30 weeks, 30 to 40 weeks, or 34 weeks, and then greater than 35 weeks. So these are closer to the term there. And then they will break it down based on postnatal age. So are they less than 2 weeks? Are they greater than 2 weeks? And you can see here how it gets less and less often you're giving it. So if you have someone who's premature and they were just born within 2 weeks, you're giving it every 48 hours. Versus here you're going to see 36, 24, and that's pretty much as frequent as you'd want to do it, right? So this is why you got to look this stuff up. Careful, especially if you're not used to dealing with type of patients here. You want to be able to find that information and use it according to actual patient characteristics there, not just use a one-size-fits-all sort of mantra with this kind of stuff. Hope that makes sense. Yeah, I know we've gone over some of the stuff before, but I like to kind of recontextualize it now. We know a lot more about drugs than we did, say, back in the summertime. So that's why I like to talk about this now. Again, other issues you can find with renal tubular development includes things like, because they're immature, they can't concentrate the urine as effectively. They may have reduced renal blood flow. All that can lead to them not being able to process drugs quite as easily. So again, these kids are going to have a lot of diversity in terms of their drug response. Not only is it going to be based off their physiology, but you're going to see that their pharmacogenetics can have a huge role to play here. So all of this is going to be a factor. So again, this is why you have to kind of go off of the initial dosing you'll see in the references, and then be able to adjust, be able to work on the fly to see how your patient's actually responding to these things here. Just as an example of the pharmacogenetics, they're important here. We talked about this previously, but like codeine, if you have really active CYP2D6, you can convert codeine to morphine very easily, and thus you can get more analgesia from it. But some kids may find they get too much of an exaggerated response because they're getting too much morphine. So I talked about that case where those kids, and again, particularly black patients, tend to be more likely to have this genetic factor where they have ultra rapid metabolizing CYP2D6, where they may either get really good effects from the drug, which is nice for things like sickle cell disease, or they may find, cases of CNS respiratory depression, like these kids that died after having tonsillectomies done, in the night because they had too much morphine on board. Whereas kids who have maybe less active CYP2D6, they may not get a lot of response out of codeine. It just doesn't work for them very well. So I say, okay, well, they're not going to use that. So again, that's why you may not even use certain drugs. Like we don't have codeine within 5 miles of Nemours because we're worried about this sort of reaction here. It's just not predictable, right? Because we don't do a lot of typical CYP2D6, testing. So again, when you're dosing these drugs here, look at the age-based dosing regimens. These are not great because they assume that everyone within, between 2 and 5 years of age gets the same exact dose. And I can tell you that kids are way too variable for this to really be effective. Some kids are quite large for their age. Some kids are quite small. It's kind of funny. I'm taking my 4-year-old, almost 5-year-old to VPK now. And it's wild just to see the kids that are essentially the same age. Some are twice the size of others, so it's so variable, and this really does not do enough kids justice of those that kind of fall into the extremes of weight, either low or high. Most often, you're going to see body weight dosing regimens being used here. This is most frequent. This is what you should be sticking with 9 times out of 10. Again, always cap out at the adult max. You don't want to go above that in any of those situations there. And again, you may find some kids may have varying ability to clear based on their weight, especially if they are particularly obese or things like that. But this is generally kind of our best option here. Just remember, if you get up to the adult dose, just cap it out there. We could use body weight, so we could use for most cases, but as I mentioned, we're seeing over and underdose, and they can happen in overweight children. We certainly know this incidence is going up over time, which is not great. And so there are some limitations there. Just be aware. And sometimes you'll see kids, like I had a patient who was 16, and I think they weighed like 30 or 40 pounds. And I had to call the nurse to be like, wait, is this right? Do we put in the weight wrong? Do we put in, kilograms as pounds or vice versa? And they're like, no, the kid had severe cerebral palsy and was just very, very small for their age, and so again, that's those things where you always want to double check if you can't lay eyes on the patients yourself. Body surface area is very handy because it allows us to take into account not only the patient's weight, but also their height. So by using the two together, you get a very good idea of what their surface area is, and this helps to limit. So you can have kids that are quite short, that are obese, and that is going to give you a different calculation than if you have a kid who is taller and is the same weight there. And so it gives you the ability to account for those really extremes in weight based on their height. So again, this is the most accurate way to dose medications, but is more cumbersome in terms of the calculations and whatnot. So this is mainly going to be used for things like chemotherapy. This is where I do it most frequently, is we'll dose based off body surface area because that gives us the most exact dosing for kids with really dangerous meds like chemotherapy. Okay. Just be aware there's different calculations out there, so just be consistent with whatever your practice is. And it can be difficult in some cases to measure the height or length of kids, especially if they have things like contractions due to CP, things like that. Getting kids to stay in still long enough for them to even get a height is difficult. Sometimes you may have cases where kids are wearing shoes or not wearing shoes, and so you can get varying heights there. So just try to be consistent when you're doing that to get the most accurate height possible. And then in terms of IV drug administration, again, you're going to be seeing here, this is especially important for little ones, like in the neonates, that things like the volume of drugs that you're administering can be important. It's possible giving too much drug volume can actually dilute out their hemoglobin. If they're getting a lot of drug testing being done or other lab testing, that can also dilute out their blood to some degree. And so it's always really important to make sure that if we're going to be doing things like therapeutic drug monitoring, we're trying to get all of our samples at the same time, so that way we can run multiple tests off the same sample of blood. And then we're going to look at some other things like the actual site of where we're administering, how that can be a problem or a challenge. Again, most of the time you don't want to just like hang a bag on a pediatric patient and just let it run in, because you can't really modify or monitor the volume that's going in. So pumps are super important here. It's a really big safety thing for kids to make sure we have an actual IV pump that can infuse a very specific amount of drug at a very specific rate. Make sure you're not going to give too much or too little, too quickly or too slowly, because again, you can run into a lot of issues there. Here's an example of a syringe pump that we use for our pediatric patients at Nemours. Again, you can see here that the devices will determine the size of the syringe based off of the diameter here. And then it will basically clip onto the end and slowly push this in based off of how fast you want to infuse that drug. And again, using a library is really important because it makes sure that everything is programmed in. It's not having the nurse plug in numbers manually. They can only have certain selections to make sure that we're not coming up with like non-standard concentrations and things like that. It's very safe and really important to make sure we're staying within the parameters that are programmed in there. In terms of oral administration, again, you're going to find that different measuring devices are going to have varying utility. I recommend not using spoons to actually measure tablespoons and teaspoons because all spoons are built a little bit differently. Remember, in general, a teaspoon is 5 mLs and a tablespoon is 15 mLs. But if you're actually to use different spoons, like I got a spoon from IKEA and a spoon from Walmart, they might be very different, Swedish versus American spoons, right? And again, when you're thinking about drug dosing or medications for these kids here, palatability is super important, right? So if it's like a liquid and it has like kind of a chalky texture to it, they may hate it and they're not going to take it. You have to kind of fight them just to even get it into them. Can you mix it in with other substances in order to allow them to get it in easier? So can I mix this drug in applesauce? Can I put this, does it come in a gummy form so that way the kids think that it's a little more palatable as a gummy? Not to call it candy, you don't want to do that. But different dosage forms may be different for different kids based on their sensory sort of appeals. Just look out for drug-food interactions. So if it's something like something that interacts with calcium or something like that, you don't put it in milk, for instance. Make sure to separate that out. And again, inactive ingredients can be important too. So for instance, if a kid was on a ketogenic diet, don't give them medication of sugar in it because they need to keep their carbohydrate intake low. If they have a dye allergy, make sure not to give them. If they have a red dye allergy, don't give them something that's cherry flavored because it probably has dye in it. So sometimes we'll need dye-free products in order to get around some of those things there. So just be sure when prescribing, keeping the most current weight available. Again, if you put a gun to my head and said, well, how much do your kids weigh? I'd probably be off probably by 10 to 15% if I had to guess, even though I've probably weighed them pretty recently. So just keep that in mind that you may not always have the most up-to-date weight and try to get that if possible. Always check with your available references, making sure you're looking specifically. If you have a neonate, look at the neonate section. If you're dealing with a pediatric patient, look at the pediatric section in order to keep you straight there. And then when counseling, figure out, okay, if it's, a 5-year-old, how do you talk to a 5-year-old about their medication versus an adolescent versus a parent of a newborn? It's really important to consider what their medical sort of savviness is and explain it to them in a way that they can understand why it's important to take the medication, how they need to be taking it, things like that, right? Of course, if it's a toddler, they may just still say no matter what you say, and so you may have to fight them a little bit. So I will tell you, there's going to be a little bit of drug dosing calculations here on the exam. There'll probably be like 2 to 3 questions I might put on here. I'll at least put one that's a fluid calculation question, just to make sure you guys are still capable of doing that. I will make sure that it is that the calculator is enabled. Actually, I'm trying to see. Maybe I will double check on this because you're having to take it at home. So let me double check with Dr. Murray to see if you're able to have calculators or not. I know through Canvas I can activate that, but I'm not sure through ExamSoft. So I will double check on that. I will send an announcement out. But just in case you need to do drug dosings, remember fluids. Super straightforward though, right? So for a fluid bolus, 20 mLs per kilo for a fluid bolus. That's pretty standard for most any patient there, right? Up to usually about 1 liter to 2 liters for a max. It's the maintenance fluids that some patients or some students have problems with. So just remember the 4-2-1 rule. So for the first 10 kilos of a patient's weight, it's 4 mLs per kilo per hour. So if they weigh 10 kilos, their maintenance fluid rate, you do have access to oh, that's good. So I'll make sure that's enabled for that. So there'll at least be 2 or 3. And again, I'm going to do easy calculations. You don't even need paper. It'll be very straightforward. They'll probably be the easiest questions on the test. So don't fret about that. I always have people that freak out, but you'll be fine. You've been doing pediatric dose calculations for better part of a year for me right now. So again, don't get too concerned about that. Anyway, so for the, if I had a 10 kilo kid, they're going to get 40 mLs per hour, right? Pretty straightforward. For the second 10 kilograms of their weight, they're going to get 2 mLs per kilo per hour. So again, if they weighed 20 kilograms, it'd be 40 plus 20. So they get 60 mLs per hour. And then for every ml subsequent to that, it's going to be 1 ml per kilo per hour. Okay. So if you had a 70 kilogram child, let's say if I can put that, Did I make a sticky note on here? I can. Yeah, it's funny. I have you guys put sticky notes, but I don't ever do it myself. How about this? So if I have a 70-kilogram child, what I can do is say, okay, for the first 10 kilos, it's going to be 4 mLs. So 4 kilos times 4 mLs, pick a type, per kilogram per hour equals 40. Then I'll have for the second 10 kilograms, I'm going to do 2 mLs per kilogram per hour, which equals 20. And then how many kilograms do I have left over? Well, I have 50 left over because I've only taken 20 out of that 70. So 50 kilograms times 1 ml per kilogram per hour, and that's going to be equaling out to be 50, right? So I just do 40 plus 20 plus 50. So it's going to be a total of 90, 100, 110 mLs per hour. So you could do like D5NS and 110 mLs per hour, and that's their fluid rate. That's it, right? So very straightforward. I'll make sure you guys have access to the calculator. It'll probably be a little bit simpler than that even. So don't fret too much on that. And again, if you can do this easy, and again, this doesn't even require a lot of like knowledge about drugs themselves. It's just math. These should be easy points for you. So hopefully that'll make a sense. So post it up, you guys can see that. So that's pretty much it for that section. And again, I'll post an announcement about that and make sure you guys are all aware of what kind of questions are going to be on there after I talk with Dr. Murray. But other than that, so I'm going to cut it off here. So basically our test is going to go from everything past epilepsy in the neuro section up through pediatrics today. Okay, that means it's going to be covering that portion of neuro up through migraines and all that, behavioral medicine, HIV and STDs, and then up through peds. Okay, so probably more info on this one than maybe on the last one but that's also probably good because that spreads out the number of questions on any particular section. I think students like when I have more breadth than depth. That's the general consensus I get, but that's what's going to be on the exam. There may be a few calculations, but again, I'll confirm that and give you guys an announcement before, probably by the start of the week, and that way you should have that. And then your assignment will be due on the 12th as well. And yeah, so now I want to open up to you guys and gals. What questions do you have about the materials? Is there anything you're maybe not clear on, or I could go over in more detail? What do you guys think? Right, so the epilepsy questions were on the last exam, if you recall. They were, weren't they? I thought they were. I can't remember asking those questions. Yeah, so it'll be anything past epilepsy in the neuro section. But I think for after the last exam, we started with like Parkinson's and all of that. And then next week we will meet. Your exam will be from 8 to 9. Then we'll meet from 9 to 11. So we're gonna meet there. If it sounds like I'm talking nonsense, let me know and I can try to clarify that. Now remember, a lot of those, some of those anti-epileptic drugs did come up in behavioral health, so that stuff is still good to know, right? So when we're talking about things like Lamictal, worrying about things like skin reactions, when I think about valproic acid, it can cause pancreatitis and liver disease, things like that. Let's see, what do students struggle with most on this section? Probably... There's a pretty big volume of drugs that are here on this exam just because, some meaty topics like, behavioral health and all of that. It's probably just keeping the drugs straight, right? So trying to remember what drugs go into which categories. I tend to find that's a challenge, especially like with HIV meds, because a lot of them end in vir, so it's hard to know which ones are a protease inhibitor versus an NRTI versus an NRTI. So what I would say for that is like, and again, I don't know how much you use this or how many of you use this, but I recommend like doing like quick flashcards and talk to some people about this. One thing I find that students will do with flashcards is they'll have like, a drug on one side, and on the back they'll write like a mini like encyclopedia about every fact known to that drug. Those are not super effective flashcards in my mind. You want like quick recall of facts. It's a flashcard, it's not a flash book, right? So you want to have like, okay, ritonavir on one side, and on the back it's a protease inhibitor. You want to have, I think something like, atomoxetine, okay, SNRI for ADHD. Something quick. That way you can try to make those quick associations in your mind, because on the test, if I say a question of like, which one of the following is a protease inhibitor, and I have 4 drugs, they all end in vir, unless you know it, you're gonna be guessing, right? So that's one of the big things I find people struggle with. So just remember to try to find ways to make quick associations in your brains. That way, when you see it on the exam and you have 5 choices and they all look real similar, you can be able to identify them based off of just memory and those quick recall that you have based off what you learned. So Christine's asking, is atomoxetine used as a monotherapy or as an add-on for treatment of ADHD? I would not use atomoxetine plus an amphetamine. That would probably be too much stimulant action there. So it would be an either or sort of thing, right? So you may see atomoxetine by itself or something like Adderall by itself. You're not used to 2 together. Now, do I see stuff like Adderall plus guanfacine and clonidine or clonidine? Sure, absolutely. I see that in some more severe cases. I think I had a kid not too recently that I think was on Adderall. They might have been on Vyvanse. They had clonidine at nighttime. They were on, they had a whole host of behavioral health issues. They're on an atypical antipsychotic, mood stabilizer. So sometimes you see a whole host of things of drugs, but I would not use atomoxetine plus one of the stimulants, the amphetamine-based drugs. What other questions do you have? So like if I asked a test question, I said, okay, patient's taking Vyvanse during the daytime at school, but they're complaining of insomnia at night. What could you add on to manage that insomnia? Then you probably say something like clonidine or guanfacine as an example. You wouldn't put atomoxetine as an add-on at that point, because that would just make them more stimulated, if anything. What other questions can I answer for you? If you are don't have anything, you can always bounce off. That's fine. I don't mind. I want to stay on here for a minute or two just to see if anyone had questions I could try to address. Some people like to pause me and stuff, so they might be a few minutes behind, but. And of course, you always email me, so the sooner you email me, the more likely I am to get back to you. Please let me know if you have any challenges or problems or questions or anything like that. All right, well, I don't see anything, so I'm going to go ahead and end the stream. But again, if you have something, feel free to email me or message me on Canvas, and I will get back to you. And yeah, good luck studying, and I will talk to you all soon.